One of our PhD students at the faculty doctorate in public health here at the Universidad Nacional de Colombia. The title of the thesis in Spanish is Compatibilidades en las multiplicidades, el uso de dispositivos médicos en la sala de operaciones. And I'm going to try to make a translation, compatibilities in the multiplicities in the use of medical devices in operating theater. The referees for this thesis are going to be Professor Rosibel Prieto Silva from the Faculty of Nursery here at the Universidad Nacional de Colombia. She's a nurse and has a doctorate in health sciences from the Escuela Nacional de Salud Pública, Cuba, and a postdoctorate in the studies of drug phenomenon in America Latina and the Caribbean from the Center of Addiction and Mental Health, Toronto, Canada. The second referee is Professor Lange Esnelvar. I hope I'm pronouncing it properly. He's a medic of the University of Campinas in Brazil. He has a doctorate in ergonomy from the University of France. He's now a professor at the Department of Production from the School of Polytechnics at the University of Sao Paulo, Brazil. And the third referee is Santiago Martinez. He's a medic from Universidad Nacional de Colombia with a master's degree and a doctorate from the Universidad de los Andes here in Bogotá, Colombia. The director of the thesis, or the tutor of the thesis, is Professor Olga Restrepo. She's a sociologist with a master's in sociology of Universidad Nacional de Colombia and doctorate in sociology from University of New York, United States. And she's now titular professor and coordinator of the PhD program in human sciences, human and social sciences at the Universidad Nacional de Colombia. Her co-director is Andrew Imada. He is a psychologist from the University of San Francisco with a master's and a doctorate in psychology from University of Ohio in the United States. I hope this came through more or less. Karen is going to have about 45 minutes to do her viva presentation. After that, the referees will inquire about the questions they have, the comments they have. Then, if somebody in the public, because this is a public presentation, wants to address the student, they are entitled to. And finally, we will give the possibility of commenting to the director and co-director of the thesis. So Karen, it's your turn.
Okay. So thank you very much. Good morning to everybody. This is about compatibilities, and we have a problem with the compatibility of the font. I was not told that I couldn't use my computer. So I just hope that it is not so bad. Okay, and the other thing I want to say before beginning properly is that I decided to put the text in English and in Spanish. I don't know if it was a good decision, but I have already done that. So I just hope that for the people that are not like me, that for English is not the mother tongue, it's helpful. Okay, this is the agenda I have thought. It is a typical agenda of a paper presentation, and I decided to do it this way because this gives me the opportunity to discuss some of the points that my evaluators commented. We will have an introduction, then we will discuss a bit about the methodology. I will present briefly the results. I will address some points in the discussion and then the final considerations. Well, in the introduction, I will talk what I call the ABC of the project, just that we know what we are talking about, a short justification, then the research problem and question, and then I will present the project as something situated in time, space, and participants and field of knowledge involved. So the purpose of this research is to contribute to public health as a problematic field, considering bodies of knowledge that deal with the relationships between the human, social, and the technological. And these fields are ergonomics and practice field. The project is centered on the use of medical devices in healthcare institutions, and specifically in operating room or operating theater. And I will present a case of study because operating room is still too broad. So I decided to work on orthopedic surgeries at the second level state hospital in the city of Bogota. Well, to understand briefly the problem and the theme, medical devices support almost every process in healthcare, from prevention to clinical care, and this influences patient safety, healthcare performance, healthcare staff safety, information reliability, process reliability, procedures efficiency, and procedures effectiveness, just to mention some aspects. Medical devices represent also a big challenge and economical investments for these institutions. On the other hand, medical devices don't act alone. They are used by different users, and they involved most of them in an invasive interaction and stressful situations. But they don't act alone, as said before. There are other medical devices and other people that are interacting with them. And the trend is that medical devices have more functions, more diverse functions, more complex functions, different product architecture, and different interfaces. This demands new skills from the healthcare staff, but also represents a dependence on providers in terms of training, installation, maintenance, spare parts, etc. So in short, we have a very complex scenario where we have a lot of actors playing a role. If we think medical devices as a technology, first, the World Health Organization classifies or says that medical devices are one health technology. However, technology is not just the physical objects, but if we talk about technology and we take concepts from Bitter and Pinch, for example, we're talking about activities and processes and what people know, what people do, and how people do things. So we are talking about objects and subjects in interaction. And we are talking about knowledge dynamically involved and generated through these relationships. When we think about the operating room, the type of technology that is generated there can be described like complete task. Some authors like Floyd and collaborators talk about this, and it refers to actions that require in parallel and very high level of knowledge, abilities, coordinations, and communications. So we are not talking about repetitive or easily recognizable actions. The other point is that there is a problem when you are trying to understand this kind of technology. And the closer you get to the detail, the more difficult it is for the researcher who is out of this theme to understand it. This is because there is something called tacit knowing involved. And tacit knowing has to do more with not what you know, but what you are able to do. So basically, the World Health Organization recognizes medical devices as a health technology. However, my point is that a medical device by itself is not enough to be considered a health technology in a broader sense. It becomes part of a useful specific health technology when it is used, when a medical procedure is enacted, when it interacts appropriately with other actors like different medical devices, healthcare staff, patients, healthcare institutions, providers, norms, etc. This appropriate interaction may be called initially compatibility, and a non-appropriate interaction may be called incompatibility. I have to say that these are the initial broad and imperfect definition of compatibility. However, there is evidence of non-appropriate interactions or incompatibilities in the usage of medical devices, leading to serious consequences in procedures, performance, patient and healthcare staff's health and safety. In order to improve compatibility, from ergonomics, two assumptions are underlying in the research and development of medical devices. First, that it is possible to predict incompatibilities between medical devices and users or systems. And second, as incompatibilities can be predicted, it is possible to avoid them through control mechanisms like guidelines, norms, and standards, applied along the design, production, procurement, and incorporation, and availability stages. So this approach is leading to improve compatibility between independent medical devices and users, but it is necessary to look beyond isolated relationships and understand compatibility in the performance of a specific medical procedure, emerging technology. The point is that actors' compatibility in a medical procedure performance is far more complex than usability of a specific medical device. So the research question I have and the general objective is how to understand the use of medical devices operating room from a system view and as socio-material practices. Then the objective is to understand this compatibility during their use as part of the operating room technology, as said before, from a systems approach and from socio-material practices. I said at the beginning that I was approaching this from ergonomics and from theory, practice theory. So systems approach is one of the basic points of ergonomics. Other objectives are to apply approaches from systems analysis and system thinking for the understanding of the case of study, and to apply research approaches that do not start from a priori categories in order to enrich the understanding of interactions complexity in the use of medical devices. So now I will locate the project in time, in space, and actors. So I began in 2009 in Colombia, and then I developed part in Germany, and then I returned to Colombia. First were the seminars and courses about public health that I had to take. Then came courses about social studies of science. Then I did my internship at the Institute of Ergonomics at the University of Darmstadt. And then I developed here the case of study and had several presentations and discussions with the community, academic community of ergonomics. Who participated in this? Well, the direction, as you know, is Olga Restrepo, Dr. Olga Restrepo, and Dr. Lange. In the formulation participate different persons. Basically important were for me Mario Hernandez and Cesar Abadia, and in Germany Professor Ralf Ruder and medical doctor Andreas Behrendt. theoretical fundamentation, they were very important. What I learned from Professor Ashmore and the different scholars that work with active network theory, like Bruno Latour, and post-end, like Anne-Marie Moore, for example. And then from practice theory and dialectics, and from ergonomics, Gabriel Garcia, and from systems view, Joel Berlusconi. In the development, there were several people that participated, from engineers to ethnologists, designers, and medical doctors. And then I had also the collaboration of other medical doctors and experts on data processing, and also the evaluators from the project, and now that are evaluated my project are contributing to this project. So we see that there are people of different areas like ergonomics, social sciences, health, and systems. About methodology, this is a qualitative interpretative study. I will present some considerations about complexity. These are not the only ones I had, but just because of time, I will just concentrate on that. And I will explain the phases of development and some of the methods. So basically, according to John Law and Anne-Marie Moore, there is complexity when things are related but they are not added, when their events occur but not in a linear time, and when the phenomena share a space but they are not able to be mapped in terms of just one group of coordinates. So this applies to the use of medical devices in operating room. But how to describe and to trap this complexity without coming into reductions and simplifications? So these authors propose to have multiple ways of ordering and a non-linear approach, among others. And so I take one of their metaphors and this to use or to organize it as a sketchbook, where we have different sketches and each sketch organizes information in a way and the other in another way. So each of them show different things. So the phases of development, we had 4 phases. First, a theoretical exploration of it. Second, field study. The third, the process and analysis of information. And then the structuration and writing of the document. About methods of data collection, we used ethnography, or traditional ethnography, based basically on field diaries and interview recording, but also what is called focus ethnography, with video recording and also the use of tools of participatory learning and action, basically to grasp this implicit knowledge through the use of metaphors. So here we have a 3D representation of the operating room where I did the study. And as I said before, we use field diaries and interview recording of all the operations we could see, live. Then we had a camera with a wide angle where we could take 170 degrees. So we could record all what was happening there, what could be recorded. But also we had the opportunity of use the eye tracking. So glasses is a technology that the medical doctor and the different healthcare staff used in some operations, so we could record what the healthcare staff was seeing, in a way. In the participatory learning and action, we did several workshops where we used brainstorming, for example, and then pair ranking and other methods. We also worked, as I said before, with metaphors, with images, so that we could grasp more of this implicit knowledge. And then we also asked them to draw and to draw their problems and to use other kind of languages to come to the different problems. Regarding the results, I will introduce briefly each sketch. Then I will explain briefly also two cases of medical devices understood through the different sketches. One is a polyester thread, and the other one is the anesthesia machine. So the sketches were also developed in different moments. Some of them were more theoretical explorations, and others were more practical explorations. So the first three sketches that I organized in the final document as annexes, and not in the body of it, well, have been already published as articles or as papers. And they give account of a moment where I thought in a certain way. I must say I tried in a previous version to put them in the body of the text, but it was not possible. I have changed to the time. But they give account of that historical moment and of what I thought in that moment. The other 6 sketches are a description of the case of study. And the whole of them make the dissertation. The first sketch about, well, it's called Compatibility in Multiplicity towards a complex understanding of medical devices use. What I do there is basically I introduce the concept of compatibility and compatibility in multiplicity from the usability, ergonomics, and viewpoint. So this offers an initial definitions of compatibility and compatibility in multiplicity from a theoretical approach. The second sketch from human being to social subject, unfreezing ergonomics and implication for understanding and intervening health disease process, deals with a bit of health disease process and concept of human being and social subject in ergonomics and the implications of these concepts. So there I discuss the limits of ergonomics hegemonic mainstream to understand health disease process in relationship to human beings and technology. And I also acknowledge the different dimensions like history, project, structure, agency, motivations, and power as other aspects that normally, or traditional ergonomics, or the hegemonic mainstream of ergonomics is not dealing with. The third one, learning from doing, chances and constraints of studying medical devices, presents a study of an anesthesia machine through usability methods, including considerations about methods. There, we discuss about the cost-benefit relationship between quantitative and qualitative methods, and we also classify methods according to their suitability in field studies. It was important to decide which methods to apply in my case study. Then the next sketch deals with the definition of medical devices based on local regulations, the concept of technology, the relationship medical devices and ergonomics, and the limits of ergonomics. It is basically what I presented in the research problem. The second one, an overview of orthopedic surgeries and the state hospital, makes an introduction to the institution, the features of this type of surgeries, orthopedic surgeries, the general processes involved, and also an explanation of the processes as a socio-technical system. The results are a preoperative process or seeing the perioperative process as a result of coordination of several processes, and the identification of socio-technical systems that are used further on. The next sketch, surrounding factors of approach to context within text, deals with the what we call PEST factors, which means the political, legal, economical, financial, social, cultural, technological, scientific, and ecological, geographical factors. And there I present a relationship with the context within the text. And here I show how compatibility in the use of medical devices is determined by the needs of the community, policies of administrators, design of the medical device, and market factors. The next sketch, operating room as a system, goes deep in a system analysis, but more, I mean, there's where the most part of ergonomics is applied, and then let's say that so the more traditional view of ergonomics, although it is not really a traditional one. And the result of that is basically the identification of critical interactions. So here I am not, this sketch doesn't show too much compatibilities, but incompatibilities between medical devices and other elements of the system. And the last sketch, doing the best with what there is, or what is there. Social material practices in the use of medical devices in the operating room. Deals with interconnected elements that are part of practices: body, mind, things, knowledge, and structure in processes. So it offers an approach to socio-material practices involved in the use of medical devices in orthopedic surgeries, and explains this compatibility as routinary ways of actions that condition compatibility in the use of medical devices. So the first case I have is the polyester thread. This is a medical device of in the classification of the INVIMA, it's a low risk device. However, the problem is that, before the problem, this device is negotiated not by the institution but a group of institutions. I mean, it is a massive supply. So this hospital doesn't control which provider will sell it, will provide it. So when there's a problem of quality, they can't say don't buy it because they don't have the power to do it. So we could say that this thread is a supply of possible massive negotiation, where the control of it is not in the hospital, but in this higher level of decision making. However, this, when we see it from an ergonomic system, as part of the ergonomic system, this thread is a device that allows to put together two, I forget how to say the heel. Tissue. How to join two tissues. And there it's interacting with hands, with gloves, with the body of the person, etc. There, the interactions, the fear, sorry, and if we see it in a different relationship, this thread that is now a non-absorbable thread is thought to help in the reparation, in the repairment, or to repair a tendon. So the problem is that if it doesn't work properly, it won't repair the tendon. So in one case, we saw how the orthopedist was trying to solve the situation, and the thread didn't work. It broke. And he tried again, and it broke again. When every time the orthopedist put tension on it. And again. So at the end, he made a report of non-conformity, and he considered that the result of this was catastrophic for the person. So there we see that as a threat of bad quality in relationship to the tendon of the person, it is a catastrophic situation, or yes, a catastrophic result. So these are just some examples of how a threat can be different things depending on how it is related. Anesthesia machine is also an example of it. There we go to another, to a biomedical device, equipment, and according to the INVIMA, so this is a higher risk device. And this anesthesia machine, in relationship to the anesthesiologist, but to a lot of things, are like the login of a surgery. If there is no anesthesiologist, or if this machine doesn't work, they can't operate. So, in this sense, the anesthesia machine is a logging of the operation. But this device doesn't serve only just for putting the anesthesia into the patient, but it is also it helps to breathe, so it can be used to breathe. So it is in situations, for example, when there is a football game and people celebrate, and they after celebrating, they became, that changed to violence, and so they begin to kill each other, and so then this hospital is in a very complicated place of Bogota, in the south of Bogota. So the hospital gets a lot of people that are injured, and the operating rooms, all the operating room area becomes an intensive care unit. And so the anesthesia devices are used to help support people. The point is that the next day, when they want to operate, none of the machines work because they were, let's say, that's overused. So the providers tell that people overuse it that they shouldn't, but they did it because so they could save lives. Well, there are many examples, but there's no time for doing that. So I will go to the discussion. I will start just 3 things: the concept of the compatibility, the concept of multiplicity, and some limits of this study. When I began, so I have 3 definitions, theoretical definitions of compatibility, from the usability viewpoint, from the microergonomic viewpoint, and from the and plus and viewpoint. So these definitions, well, were useful at the beginning, but I had to change them through the process. So after applying it in the systems approach and in the understanding practices, so I changed it to saying compatibility as an interaction, as positive interaction, as a trend to balance and to the solving of controversies. And incompatibility, I define it as difficulties, incidents, adverse events, accidents, or occupational diseases. So, as a systems view, then I could see the actions, the elements that were going inside, the emergent properties, and what was going out, the outcomes. And from the social material practices, I could see the interaction, patterns of interaction. So, at the beginning, I was talking about compatibility and incompatibility as something appropriate and inappropriate. And this concept has problems. And one of my evaluators discovered it with a lot of detail. And that was very good for me because I tried a lot of times to make a graphic of it and I was not able. And I understand why I was not able to do that. And because basically they are in different axes. So, because appropriate and inappropriate are categories that involve other things like politics, policies or ways of understanding things. You can ask appropriate for whom, yes. So we could say that, for example, the using the anesthesia device for keeping a person alive is not appropriate for the providers of the anesthesia machine, but it is provided to the hospital. It is appropriate to the hospital and to the person to keep them alive. So there are relative concepts. Regarding multiplicity, if I talk about multiplicity in the sense, the real sense of mole, or as different orders, I use both because I deal with this project using different orders, so different logics, different frameworks, different styles, discourses. If you read one sketch, you will see that it is written in a different way than another sketch, for example. But on the other hand, as I've explained with the thread example and with the anesthesia machine, one medical device is more than one, but is less than two, which is the basic concept of multiplicity and of this fractal dimension that Animal introduces. About the limits of the study, what do I leave out? Oh, I don't leave the patient totally. He appears there, but I don't really care too much about it, I must say that. I was concentrated on medical devices. The record was something, it plays a huge role. However, I was concentrated on medical devices, and due to need for limiting the study, I let it out, yes. And the microorganism, yes. Well, it was implicitly there. I never talk about the microorganism, and well, one of my authors is totally right. It is, I mean, a lot of actions I've done because of the microorganism. The reason why I left all this out is the need to limit the study. It was very difficult for me to, especially when I was from this ethnographic approach, not to lose the focus on the medical devices, and that's why I did it. But the other reason is because of anthropocentrism, which is something that is part of me in a way as an industrial designer and as a person working on an economist. So we tend to think life as human life, and so we ignore other lives, which is of course a big mistake. But well, that's it. Yes. So regarding ergonomics, as another evaluator rightly mentioned, this is more from the human factors approach, more of the systems approach, which is more from a positivist and post-positivist approach. But ergonomics doesn't just work on that. They work also from a constructivistic approach and from a participatory approach. So these other approaches, or really paradigms, offer quite moralistic viewpoints. However, I decided the other one because I was more accustomed to it, and because it would have been more difficult to separate from practice theory. And also, I left out something called the psychodynamic of the work, where one of my evaluators is an expert, and I didn't know anything about it, I must say, before he recommended some lectures about it. Unfortunately, they are in French, so I tried to learn about it, but I can't say that there was too much in these 2 weeks. So, about final considerations. About the harmonic trends of ergonomics, its ontology and epistemology and methodology, I think that we need to incorporate methods oriented to grasping this tacit knowledge. Normally when we are working on ergonomics, we observe and we ask. But when we ask, what are you doing? People won't say what they are doing. They say what they should do. That happens every time I do that. So you can't understand what they are doing asking them what they are doing. So you need other methods to grasp that. And that is where ethnography, and especially focused ethnography, plays a big role. Using these metaphors and coming with these images, asking people to think about these images or to draw their problems, and then they talk about that. And so the results are even very, well, they're more richer, they're richer, yes, more richer, yes, than when you just work with explicit knowledge. The other point is that there is a trend, or I discovered doing this work, the trend towards system analysis rather than system thinking. So most of ergonomic tools, at least in the positivist and post-positivist paradigm, are analysis, work on analysis, and not on system thinking with something different. They are complementary, but we need also to work more towards that. And the third one is that there is a limited understanding and debate about the concept of interaction. I mean, interaction is in the ontology of ergonomics, but there is not too much debate about what interaction means. About ethnography and its relationship to ergonomics, there is a huge value of approaching a situation without a priori categories. For me, it was a really changing world. It was custom to have a checklist and to go to blah, blah, blah. And then, because we have also a limited time to do things. But working with field diaries as a tool for understanding interaction gives a totally different approach and a lot of more things. And so this ethnography, both ethnographies, can be applied to ergonomics. The traditional ethnography could be used in the training of ergonomists, and focused ethnography more in the when you are doing a diagnosis or when you are doing an intervention. One of the most important conclusions I have from this is that is the relationship between systems and practices. I mean, that was a question that I had from 6 years ago. So they were saying, but what is the difference between systems and practices? Both are talking about people, about things, about interactions, blah, blah, blah. But the point is that they organize things differently. Systems organize things according to the purpose, but practices organize things according to the routines. And routines is something quite more complex. There is intentionality, but intentionality is just one part of this worldview and of other things. So in a way, the purpose or the systems view is a kind of neutral, of perfect, of and I think that's why many of the systems don't work. I mean, if you think about the healthcare system, so it is thought to provide health, but in the practices it deals with disease, which is something different. Regarding, some contributions to academy, so the epistemological and methodological approach can help in the training of professionals, so that they are more conscious of complexity and relationships involved in the use of medical devices. So if we change the way that professionals are thinking about, we are contributing to that. Another one, and I think this will be a very, very interesting field, is to develop inter- and transdisciplinary investigations offering more holistic understanding of and solutions to problems associated to the use of medical devices. For example, studying the microorganism from practices and also from some systems. I think it would be amazing. I mean, I forgot it, but now I see it would be really, really interesting. And to public health, some contributions. I mean, the EMA classification, of course, it is focused on cultures and regulations, is very limited. All medical devices can be understood as an ensemble of actors, and it's through this ensemble that medical devices acquire their meaning. Other point is that the now, or the today, of the medical device is defined by its journey, what has happened before it, and the project, what is expected to be used. And this is affected by the agency of those who lead, who work, and who use the healthcare institution. Other contribution is that quality of medical device is not just something that is in the object, but depends on the relationships. And this study shows also the understanding of medical devices, medical practices, patient safety and healthcare and health management, including when it is done in precarious conditions. And finally, the importance of including not just systems view, but practices understanding when they are making policies or whatever they are doing. So I want to thank you to all these people that I mentioned before, and many others that help. But this project is also system and practice, can see also in this lecture with a lot of actors there. So I really want to thank you, my directors, and other people that are not here but that didn't participate, but if they wouldn't have been there, I wouldn't be able to concentrate and do this. I would also thank you to the university and to the Institute of Ergonomics in Darmstadt, to the International Ergonomics Association, to my company, our company, and to the hospital where this study was carried out, and to all people that participated in that. And above all, to my family that had to live all these practices and all this situation that grow in this process. So thank you very much for your attention.